Good evening from the Gail Lemron Auditorium on the campus of Embry-Riddle. Welcome to the Embry-Riddle Speaker Series for tonight. I'm Marc Bernier, the moderator for tonight's event. When one thinks of Embry-Riddle, they first think of aviation, aerospace, engineering, business, homeland security, just to start things. But do they think of medicine? Generally not. More and more, they think of research with the new Microplex and a new magazine that we're featuring tonight called ResearchER magazine. Our story is about one aspect, one story within that magazine, the study and the subject of hip dysplasia. We're going to introduce a panel to you, but first, a few words about tonight's event. From the Dean of the College of Engineering, I ask for Dr. Marc Bernier to join me for a moment and welcome you to tonight's event.
Thank you. Good evening and welcome. Picking up on that theme, Embry-Riddle is known as a leader in aerospace and aviation, but the university also rapidly growing research and earning a reputation for its technological prowess. While the top technological achievements of the last century were things like nuclear power, personal computer, the airplane, the automobile, television, rocket, the engineering grand challenges of this new century are making solar energy economical, carbon sequestration, access to clean water, advancing health informatics, engineering better medicine, reverse engineering the brain, cybersecurity, just to name 7 of the 14 identified. These are interdisciplinary, complex problems with social, policy, and quality of life implications. Research to address these challenges helps improving the quality of life and securing a prosperous future for mankind. This is the purpose of the research that will be presented this evening, which is being featured in the spring edition of the ResearchER magazine. Thank you very much.
Thank you, Dr. Bernier. Let's begin our discussion as we introduce our panel. And in this program, which is very different from what we normally do, we're actually going to have a demonstration of the procedure, and then we're going to take your questions. I want to introduce 2 Embry-Riddle professors seated left to right as you watch. There's Dr. Eduardo Divo, along with Dr. Victor Huaymave. And joining us tonight, too, is the Arnold Palmer specialist, Dr. Charles T. Price, who's with us tonight. Gentlemen, thank you for being with us. We'll introduce you to a mom whose child went through this procedure, but let's begin by, when people think of engineering and they think of Embry-Riddle, they're not thinking about something medical. They're certainly not thinking about hips. So, Eduardo, tell us, how did you come into this? Because this isn't something new, but how did this subject come to you?
Well, good evening, everyone. Thank you for having me, Marc. And the subject came to us as a result of collaboration with Arnold Palmer Hospital. We had worked in a variety of different problems over the years. And if you think of, for example, hip and the hip dysplasia is an engineering mechanism. It's a ball and socket type of mechanism with 3 degrees of freedom. Okay, so it flexes, it extends, it abducts, and it rotates. Such as what the type of things that we learn in kinematics and dynamics. Some of our students are sitting in the audience today. It's just a lot more difficult because what we're used to in engineering is to treat certain things linearly, such as the relationship between how materials deflect as a result of applying forces. But in biological tissue, all of that goes out the window. Everything becomes more complicated because the relationships, these what we call constituent relationships, cease to be linear. And it becomes a lot more interesting, challenging problem. So this problem in particular was brought up to us by Dr. Price as a result of a story that he would actually share with us that's in one of the websites from the Institute of Hip Dysplasia, International Hip Dysplasia Institute that he directs. And it was a very fascinating story of a celebrity who had a child with a condition that requires some mechanical type of analysis. And ever since, and I think we're now on our 8th year of this endeavor, we've gone from very simplistic models, and when I say models, computational models, 3D representations of the articulation itself, addition of the muscles, addition of the tissue, to what we have today, which is a sort of a patient-specific, a more anatomically realistic model of what an infant would be, with different levels of dislocation of the hip or dysplasia of the hip, with different levels of flatness of the socket where the femoral head goes, and we'll explain all this terminology as we go, and obviously with completely different results as we apply the conditions to the model. And the idea here behind all these is, how do we come up with a set of guidelines that govern this mechanism?
And you want to do this without surgery. That's the big key, right?
That's the key. Dr. Price works on this procedure that basically is affected by a passive constraint device. It's a device that's called a Pavlik harness, and it's one of many harnesses that I use out there. It's very pervasive here in the US, that basically tries to mitigate this condition without the need for surgery. So needless to say, it's very challenging to convince funding agencies to sponsor this type of work, because it's a project that does not require drugs or surgery. So,
well, without putting out identities that may not want to be out, we understand the entertainer that you mentioned to me a couple of months ago put a large amount of funding into this because was it his grandchild or
his son? So Dr. Price can talk about this.
I'm going to get to that one second now. Victor, you have worked with Eduardo
yes.
for some time. You were both at UCF?
Yeah, I was at UCF. I was actually an undergrad student, and at the time, UCF didn't have a bioengineering program, so I was in mechanical engineering. So I remember it was on one of my fluid mechanics class that I was taking at the time, and the professor said, well, you know, I do things with fluids related to the blood. And I was like, wow, I didn't know that. So then I looked into it, and then I started working for Dr. Kassab, and Dr. Divo was already a professor there, so I started collaborating with them with the projects, and then I went to grad school. And the project on hip dysplasia was my PhD dissertation, the biomechanics of hip dysplasia in infants.
And our audience will be able to follow this in the current issue of ResearchER magazine. So Eduardo and Victor, you've been at Embry-Riddle for how many years now?
I've been fortunate to be here for the last 5 years. I migrated from UCF to Embry-Riddle.
Okay,
And
Victor?
this is my 3rd year.
This is your 3rd year here.
Mm-hmm.
Okay. Now, the International Hip Dysplasia Institute, Dr. Price, when these gentlemen told me about it, I didn't even know it existed. Forgive my ignorance, I didn't know. But Melody, the mother of my children, she knew about hip dysplasia, and she had heard of this. Is it something that the research was working to try to stave off long-term problems for people when they become adults by getting it when they're young? Was that the key to this, or did we notice that there's hip dysplasia throughout the ages of a person's life?
Those are good questions, Mark. Could I show a little slide about hip dysplasia, a couple of pictures, so
let's do that.
We're all on the same page about what it is. Most people, well, before you play that, Mike's upstairs running things for us, but most people think of dogs when they hear hip dysplasia. A lot of large breeds of dogs have hip dysplasia, and so we know they have it, and a lot of people aren't aware that hip dysplasia is the most common abnormality in newborn babies. It's actually more common in humans than it is in dogs, and it's the leading cause of hip arthritis in women under the age of 50. Across the board, it accounts for 10% of all total hips in the United States, and of total hips done before the age of 50, it's 1 out of 4. So most people aren't aware of the magnitude of the problem of hip dysplasia in people. And it actually has some similarities to dogs that we could talk about. But hip dysplasia, this little video will graphically, it's nothing bloody in it or anything like that, but it'll give a little idea of what hip dysplasia is if we could run that.
The hip is a ball and socket joint between the pelvis and the femur, articulating between the femoral head and the acetabulum. Surrounding the joint is a complex capsule that has 3 distinct thickenings that spiral around the joint that are loosely referred to as ligaments. Capsular laxity from whatever cause is the most common underlying pathology in the development of hip dysplasia. This laxity may produce secondary changes in the hip, which may be well established at birth or develop in the postnatal period if the laxity persists. Capsular laxity leads to a number of pathological scenarios. Subluxation. This refers to the femoral head sliding within the acetabulum, but without completely losing contact. This is felt as a gliding sensation, and may at times be difficult to appreciate. Dislocation. This is where the femoral head loses contact with the acetabulum. The femoral head may be dislocatable, able to be pushed out of the socket, or dislocated, not in the socket. Dislocations may be able to be put back in the socket, that is, reducible, or remain stuck in the dislocated position, that is, irreducible.
And so that's all the video. What the engineering group has been working on, we've been working on the irreducible ones because they're the ones that give us the most trouble. But I've been practicing children's orthopedics for longer than I care to admit. Actually, CT scans are a relatively new invention, believe it or not. And our treatment for hip dysplasia really hasn't changed even since before the development of CT scans, and for 40 years the treatment's been the same and the results have been about the same, which isn't that great. But we used to call it congenital dislocation of the hip because we thought it was like a birth defect, like others, like other things. But now we've recognized that it's a mechanical disorder, that it's more common in firstborn babies and babies that are born in the breech position, that's buttocks first. Their hips get stretched, the ligaments get stretched. And from positional things, or even after birth, you can position babies in an awkward way and cause the hips to dislocate. So the hip is totally normal, except that the ligaments have been stretched like an athlete with a torn knee. And the trick is to get it back in the socket while the baby grows and the hip can become solid. And we've got a mom here, Lauren. Can I show a couple more pictures?
Yes, please go right ahead, sir.
If you could show the next one. This is a Pavlik harness that Lauren will recognize, and this is what we put babies in to hold their hip pointed toward the socket to try to get it to go into the socket. The next slide. And you can see on the left is a baby's hip, and you can see that the socket itself is very shallow compared to an adult hip. I think you can see the socket up there on that image. But babies' hips are very immature, so they come in and out of the joint very easily, and the cartilage in a baby's hip is kind of like the cartilage of your ear. You can bend it and twist it and it doesn't hurt. Well, if the baby gets twisted a certain way, that hip can pop out and can't get back in. And so about 1 in 500 babies actually has a dislocated hip. And then after birth, it has to be in the socket so the socket develops properly. I think we've got one more slide or two more. Yeah, this is the adult. Now there's an adult form, and I think you see the line on the left on the normal shows you how deep the hip socket is in a normal adult, but we see adult hip dysplasia, which the socket's very shallow. So in babies, we see instability and dislocation, but we also are discovering a type that's been out there for years. Doctors weren't smart enough to figure it out, that a lot of hip dysplasia is just the failure of the socket to mature properly. So the socket's too shallow. And a lot of adults have hip dysplasia, and that's what causes the hip pain. So young women that come in with hip pain, we're discovering that a lot of them have this type of hip dysplasia. And so this is all mechanical. The hip responds to mechanical forces. And the last one is our engineering team. So we've been working with these guys for 8 years, like you said, and they've made amazing progress. the story of how this happened, I have been an academic orthopedic surgeon running a educational program over at Orlando Health for a long time and teaching orthopedic surgery in children and serving as faculty for our orthopedic surgeon training program. But the wife, well, it's actually Larry the Cable Guy. It's not a secret. You can go on his website. So Larry the Cable Guy, his wife, they had a baby with hip dysplasia that was born in Nebraska, and that didn't respond to treatment, the initial treatment, and they came down to Orlando for surgery. And I looked at it and said, well, we have to put him in the harness. And the mom said, no, we've done that. I'm not doing it. And I told him a little lie. I said, well, it'll make the surgery easier.
Did they have a different type of harness?
They had been in a harness and it hadn't worked. And so when I put the harness on the baby, I could see that if you think of Larry the Cable Guy, he's kind of got short legs and a big body.
Yeah.
And the baby was kind of like that too. So I took I went over to the harness, the place where you get the shop, the brace shop, and we actually unsewed the harness, unstitched it, and I moved the straps to a new position that wasn't from the factory. And so then they did that for 4 weeks and the hip went in the socket. And so the mother said, how did you know to do that? And the other doctors didn't. And I said, well, I'm old. I said, and she said, well, you have to teach other people how to do that. And I said, well, research is expensive. And she said, well, how much? And I said, well, and she had a whole lot of other things she wanted us to do, like have a website and teach parents and teach doctors, and we're still working on it. And so I said, $5 million. And she said, okay.
Wow.
Yeah.
Wow.
And so they funded it.
The thing that comes to mind is, could this be avoided if there was even better care when the child is maturing inside? In other words, if the mother were to refrain from certain movements, angles, diet, is there any way that this could be prevented?
No. Well, we're looking at that. Some of the research money, we're very focused on the Pavlik harness as the treatment. And that's what the engineering is all about, is about the Pavlik harness. We formed an international group with their money. It's not, so we have an international group of hip dysplasia experts from around the world, and we're doing more than just the engineering. But the engineering component is the real key. No, there's nothing the mother can do, really. We do have some nutritional research going on in England, but we found that it's not vitamin D. We're on the track of some other things, so it's not a vitamin D deficiency, but some things can predispose to it, surely. It's a combination of things. But the harness, currently we can only use the harness up to 6 months of age. And then after that, we would have to do surgery. So through the engineering process, these guys are figuring out some tricks that might allow the harness to be more effective. It only works, it works 85% of the time. And that sounds pretty good unless you're the 1 in 6 where it doesn't work. Yeah. And we don't like 1 in 6. We like 99%.
In anticipation of tonight's event, I was doing some reading about it today. And according to what I read, it said that there is less chance that this will happen to Asians and African Americans. Is that true?
There is some truth in that. And actually, it's quite common in China. And in Japan.
For the swaddling is
right. And the babies are born with their hips all crunched up like that. And if you straighten them out suddenly, that can actually dislocate the hip. And so a lot of swaddling binds the baby's legs. If you wrap the babies with the leg straight, the Navajo Indians used to do that, would take the newborn baby and wrap the legs out straight, and a third of their kids had dislocated hips. And so when they stopped it, it went way down. The Japanese traditionally swaddled, and they had a national campaign to eliminate swaddling, and they reduced their frequency of hip dislocations from 3%, 3 out of 100 people, to 0.3%. So there are some after-birth mechanical things that can be done to decrease it. Now in China, in some parts of China and in Africa, mothers carry their baby on their back in kind of what we call the M position or frog position. If you think of an African mother going to work in the field with the baby on her back, and the baby's riding like a jockey on the mom's back, wrapped up in a shawl, and that's great for the hips. Now when they become westernized and don't do that as much, then we start to see the late hip dislocations. So some dislocations occur at birth, and others occur after birth. So we know there are mechanical factors.
Dr. Price, I'm curious, because we've been addressing this from a youth standpoint. We know that one of the leading causes of death of those over the age of 70 is fall, hip fracture, and then the complications that come from that. If a person has a fall, breaks their hip, are they likely to develop late in life hip dysplasia?
No, it's something it's developed from birth. Even the babies that have a shallow socket, if the time for the socket to develop is in the first year of life. And cultures that carry their babies on their back in that baby wearing position actually have a very low frequency of arthritis in adulthood. So that M position is pretty good for hips. So there are definitely some preventive things that we're working with the American Academy of Pediatrics and some global initiatives to do prevention of the newborn baby after they're born, because that M position could substitute for the pelvic harness in some cultures.
Who developed the first harness?
Well, some types of harnesses have been around for 100 years, but the pelvic harness, the one that Lauren has and I showed the picture of, has been the most effective available. But like I said, it's not as effective as it could be, and it only works for children up to 6 months. So one of the projects we've challenged these guys with is to find some mechanical levers, or like the mom said, which way do we move the straps? Do we make them adjustable for each baby? Right now it's kind of one size fits all. And are there ways that we can adjust the straps and the constraints to make it more successful for more babies and for older age groups?
I want to turn to Eduardo and Victor to ask, this is ongoing. You have students, but this isn't the only thing you're working on to educate our audience into the research mechanism of this component of Embry-Riddle. You're doing this while you're doing other things. Can you share with our audience the other types of projects you may be working on?
Yes. As this particular project is a very it's fantastic project, because it fills you with a lot of joy to be able to employ your engineering knowledge to do a social purpose. From a social purpose, we have the fortune to work with other doctors at Orlando Health and Arnold Palmer Hospital, and in many other different areas. We in particular work with Dr. DeCampli, for example, who's a cardiothoracic surgeon, also pediatric cardiothoracic surgeon. We have a thing for kids in our endeavor, in our biomedical endeavor. We work in congenital diseases that have to do with malformations of the heart and the cardiovascular system itself. So there's a lot of engineering into that, because it's mechanical engineers and aerospace engineering, which is kind of the core of this university. We learn a lot about fluid mechanics, and those same principles of fluid mechanics apply to the flow of blood. So if there's some corrective procedure that needs to be performed in the cardiovascular system to reroute the blood to perform certain functions, so to allow the baby to live, for example, a baby with blue baby syndrome would not survive unless a surgical procedure is effected immediately. We study the effects of that procedure itself. What would the resulting pressures be? What would the resulting flows would be? We work with another cardiothoracic surgeon looking for alternatives of support devices, mechanical support devices for the cardiovascular system. I don't know if you've heard of these mechanical pumps called LVADs, left ventricular assist devices, usually employed or implanted into patients that suffer some kind of congestive disease, but can also be implanted in infants with some congenital condition. So we look for alternatives to the miniaturization of these, to the elimination of moving parts, to make them more reliable and a lot less dangerous for the cardiovascular system.
Victor, from your standpoint, the students that you're working with in these types of research, where will they go from here?
Well, right now, besides the hip dysplasia, which is also related to hip dysplasia, we're doing research on baby wearing devices. So like Dr. Price said, there are some positions that are supposed to be good for growth. So we're looking into baby wearing, doing research. So that's one of the projects that we're doing now. On projects that are applied to engineering, we're working on a new propulsion system for a wheelchair. So we're working with a company on the Microplex. So if that goes good, some of the students are going to be working with them at some point, and we have internships on that. We have another student that decided to, and actually he's here today, he decided to design a knee brace for an assisted device. So he's working on that. His purpose is to, once he graduates, to have his own business. So that's what he wants to do. And he's working on that. He's been pretty successful. He got some money, some funds, and he's on his way. So there's a lot of opportunities, either if they want to go to industry or start their own business.
Once again, in the broadcast of this event worldwide, people are so in tune to thinking of Embry-Riddle as aviation and aerospace, now medicine, and coming up with methods to make things better for people's lives. I'm going to, forgive me as I turn around, introduce you to another member of our program tonight. She is a mom who's, Tori, I think is your child. Would you step up so that folks can see you? This is Lauren Parr. Lauren, you live in
Orlando.
Okay. Did you grow up in Orlando?
No, I'm from Tampa, Florida.
Okay. Tell us about the situation involving Tori.
So my husband works in college athletics, and we move around a little bit. So we were in Norfolk, Virginia, and moved here when I was 7 months pregnant. I knew that she had been in the breech position for, I think it was 2 to 3 months. She wasn't turning. There's exercises they suggest you do. I was floating in the pool and yoga and all kinds of things, but she's a stubborn, strong-willed little baby. So I didn't do too much research. I wasn't familiar with hip dysplasia outside of dogs. So when I had her and the nurse said, oh, she has a clicky hip, we'll look into it. I didn't really know what that meant, but they took her in the next day for a sonogram, and it confirmed that she had hip dysplasia, and they came and brought this, put her in this little harness. This is her first harness. I have a bigger one too. But the tech, didn't know much about it, and we had to obviously follow up with Dr. Price's office, and it was quite the experience. I mean, you think your baby's going to be perfect and come out perfect, and obviously she was, but it was a lot to take in for a new mom. Okay,
how did she do with this? I mean, did she understand? Obviously, she doesn't know what's going on, but was she irritated by wearing it? Was she okay with it?
This is 100% harder on the parents than on the babies. Obviously, babies cry a lot, so you don't know as a new parent, is my baby uncomfortable? I'm trying to nurse for the first time, and can I hold her a certain way? Is this bothering her? Am I hurting her? A lot of our friends and family were scared to hold her. They didn't know if they were going to be hurting her or change her diaper. So it definitely presented a lot of challenges, I think, for the adults in her life. But now, knowing what I know now, she was perfectly fine. She wasn't uncomfortable.
So how is Tori now?
She's great. She's 17 months old and walking, running. I just feel so blessed because we could have just found out, within the last couple of months if she hadn't started walking that something was wrong. So the fact that the nurse caught it when she did, and we had the treatment for the first 3 months of her life, and she's a healthy, happy little girl, is just such a blessing. So. All
right, Lauren, did they indicate whether you'll have to come back for another check for Tori? Is there a procedure you have to go through?
So we go every year now. We went for the first 3 months of her life, a lot of sonograms and x-rays and checks with one of Dr. Price's colleagues. And then we went at 6 months, believe at 9 months, a year, and now we'll go every year until she's done growing.
Congratulations.
Thank you.
Ladies and gentlemen, Lauren Parr, thank you for being with us. All right. We're going to take questions from the audience shortly, but first I want to bring up Jensen Johnston, who's going to do a demonstration of how this works. She is the president of the Biomedical Society over at Embry-Riddle. Dr. Price will join us now. And I guess I will hold the microphone while Dr. Price is mic'd already, so let me give you this microphone. Okay. Maybe you can both take us through this process.
Did you want me to?
Yes, go ahead.
Well, I don't know if you can see the harness very well with the color, but there are leg leg holders where it holds the feet, and then there's a shoulder harness. So it's basically two parts. It's the chest harness, like you might wear, I guess if you're wearing a parachute or something, and the part that goes around the feet, and then these straps that are Velcroed in. With these straps, you can pull the strap and pull the baby's leg in different directions. There's one in the back that also allows to pull in different directions. And so there's, like I said, right now, we just put the babies in it, and they all go in the same way, and the same strap, and the same tension, and the same everything. But what they're working with are maybe other straps that would allow the hip to twist and turn a little bit so that it could, for the ones that don't want to go in, Lauren's case is delightful because 5 out of 6 do respond the way we want them to, but some of them don't. And then they're working with the difficult ones. The adult hip, this is an adult hip with dysplasia, and I don't know if you can see that or not, but this is a half a pelvis and the ball, or this is what we call the femoral head, and this is the acetabulum or socket. And in this case, you could see that the socket's too big. I don't know if you could see that or not, but this hip would wobble around. This is actually a model that
We printed here.
they printed this at 3D printing from a CT scan of an actual patient. And so they're modeling the adults to figure out how to reshape the socket and reshape the bones to help people with a hip socket that's grown, it's too large. So you can imagine if you're an adult and you're walking on this, with every step, the hip grinds a little bit. And by the time you're 25, that hurts a lot. By way of example, though, this is a 3D printed model of an infant hip. So when the babies are born, the whole pelvis is this size, and we're trying to get the hip back in the joint when it's this size. And they're actually a little bit bigger. This would be about a 3-month-old. It grows very quickly. So a 3-month-old is a little bigger, but they're still pretty tiny. And this again is made from models that were actually from Padua, Italy.
Those are from the actual Padua model.
Yeah, those little ones are.
Yeah, these ones are from Italy. And so if you can see, these are our very small femurs that we got. So they're pretty small when you first try to get them. And as Dr. Price was saying, it's a very shallow acetabulum when the baby is born. And so trying to get this right angles with the plavlik harness is kind of what the engineering has been doing. And we use models like this as Dr. H's research. He's been using these kind of models. As you can see up there, it's the same model that we just printed in our lab.
By the way, the babies models, the infant models, the newborns, Victor can talk a little bit about that because it's an interesting adventure too.
Yeah.
Victor, what about this? When it's that small,
Yeah.
just if you're off by a little bit, you could make the situation worse?
Well, it's interesting how to approach this type of problems with anatomy. We had to read a lot and think about that. There's a lot going on. It's not only the size of these bones, but also you have to think about the muscle attachments and where they are attached to get the proper mechanical response. So it's a complex problem. Now, about these samples, we got them from Italy, and that's something I always remember because it was a nice trip to Italy, of course, but we were working. We went to Dr. Price, and he got us access to a collection of ortolani, which is, there's a procedure named after ortolani, and if you have kids, you can see that every time you go for a checkup, they move the leg, so they're checking for dislocations. So that collection is, 100 years old, I think? And then that was pretty neat because I've never seen samples of infants. And we were able to touch them, to measure them, to take pictures, and we got scans of them. And one of the things I remember is that we have seen these models in the computers, we have read papers about it, but whenever there's a bad dislocation and then the femoral head, it's stuck in the acetabulum, Dr. Price told us that they form a false acetabulum I've never seen pictures of that, but they had a sample of that, and I was able to see it. So you have the socket, and then because of the bones are ossifying, they're soft. If you have that femoral head in the back of the acetabulum for too long, they will form another socket in there. So I was interested to see in an actual bone happening. I mean, the Dr. Price talked to us about it, but we never seen a picture of it. So that was pretty
I'm
unique.
curious about the students too. Are they all interested in medicine, pediatrics, or that are working on this research with you?
Yeah, we have a friend actually who started on this project. He went to med school. So he's graduated from med school, and then usually we had people interested in going after the master's, going to med school.
Dr. Price.
We don't want the engineers. I mean, they're welcome to go to medical school, but we need engineers because the work they're doing. One of the things that's happened is, to back up just a second, this group of pathology specimens was in the Anatomy Museum in Padua, Italy, which is the original home of a lot of anatomy studies. And in the 1918 flu epidemic, a number of babies unfortunately died from flu. And there was a researcher there who examined over 1,000 babies, young babies who had died, and examined them to see if their hips were unstable or not. And then if they were, he dissected the hips and saved the specimen. That's a little bit gory to think about, but it helped us understand the pathology. He had about 20 specimens that we were able to go in and look at, and we were the only ones that had done that. So we took the engineering people, and they actually made some very detailed measurements that doctors don't know how to do, and they calibrated it so we understand actually what's going on a lot better. And so over the years, because it's a mechanical issue, they're working on creating a computer simulation model of the infant hip, which we can then manipulate, because we can't do this work in humans. You can't manipulate a human model. You could try something in 100 babies and see if it works, but it's pretty much trial and error. This gives us a big advantage, and as Dr. Divo mentioned at the beginning, because it's mechanical, there's no pill that you can test in a lab or laboratory animal. There's no surgical implant. It's a purely mechanical disorder. So we want them to train students to do the mechanical modeling, which we can do now. They can make cars on computers and then test them. They can do the
3D technology that we have now.
The simulators for flight technology, and that's why we came to Embry-Riddle, because you do so much simulation for flight technology and CAD/CAM development, I guess, of flight simulation, airplanes, cars, you name it. You all are building them on computers. And so we've just asked them to build a baby on a computer, and they're doing it.
How do you know when this work will be completed? Is there a timeline or a hope?
Well, first of all, they've already discovered quite a few things that we've put into practice. They identified one obstacle to reduction that is in the way surgically that has not been part of our surgical procedure, but we've had several surgeons who've now implemented a release of that muscle during surgery, and they said it makes the operation a lot easier. They've found some ways to manipulate the device that we're testing. So once they've done the basic science work, then we go to the human model, and we say, okay, we're going to try this on 50 children this way and 50 that way, as long as it's within, it's not going to cause any harm. We use a traditional method for 50 and a implemented model with a different harness for 50. So that process would take us 3 to 4 years, but we've got an international collaboration of clinicians who are waiting for their information so that we can design better devices that we could then test with the basic science background, rather than just say, oh, I've got an idea, we're going to try it on some babies.
How many people work at the Institute?
Well, we're more of an institute in regards as a think tank. We have I'm actually sort of volunteer over there myself because I'm employed by the hospital, but we've got 2 full-time employees. One of them's here. Andy Younger's our executive director who oversees things, but we have about 15 physicians around the world, and we get together twice a year and go over the research projects. They've met with them. They came out to Los Angeles one time and met with our group, and they'll review their work and give them some clinical ideas, and then we discuss other things, and then we can develop some collaborative studies. So there.
Is it true that you want to get to these children as soon as possible? Up until a certain age, you're going to have a great deal of success, but if you haven't begun the therapy at a certain age, it becomes much more difficult. Is that correct, Dr. Price?
Right. It's about 6 months. And
6 months?
Yeah.
That's the window?
That's the window. But with their help, we hope to expand the window to 18 months, which would be huge. So a lot of these babies, there are some that develop later and they're not detected until the baby starts walking, and then they're limping. And so those kids need surgery. And if we could get into the walking age group, the 18-month-old, then we could have a huge impact globally. I was just down in Ecuador, and you're from Ecuador, and Ecuador still uses traditional swaddling, and they do lots. I'm going to a hospital in China in a few months that does over 200 surgical procedures a year on babies because they aren't discovered till they're walking. So those countries don't have the capacity to do ultrasounds and detect them at birth like she was. But if we could find a way to treat them with harnesses in an older age group, then it would be huge worldwide.
Jensen, explain to our audience your society. What do they do?
So our society at Embry-Riddle is called the Biomedical Engineering Society. So we're a newer club on campus, and we basically do take part in these different research projects. As Dr. Divo was saying, there's our cardiovascular projects as well as our hip dysplasia projects. So we do different research and get younger students usually involved and looking more towards the medicine side than just the engineering side.
What is it that you would like to do in your future? No pressure.
I'm actually working with Dr. Divo on the cardiovascular side, so I would like to develop something more with that and work with that in the future as well.
Jensen, thank you. Thank you for the demonstration. Dr. Price, your specialty is pediatrics. So the big question is, does the average pediatrician recognize this abnormality when they see it? Knowing the window is so small, do most pediatricians, do you think, know what's going on?
Actually, we're pretty fortunate in this country. There are some that escape, but some of them are very, very hard to detect. We've actually found that some of the dislocated hips, you cannot find them with a clinical examination. And so about 10%, or 1 out of 10, shows up late to our practice. So most of them, 90% are detected at birth or shortly after birth and have the best opportunity for treatment. But 1 in 10 still, even in our country, are found after 6 months of age. So we don't know. Some of those are probably what we call missed at birth, and some are, they develop later from swaddling or from other reasons.
Wow.
Yeah.
We're going to take questions from the audience. If you have a question or want to follow up on something, you can come right to the microphones. We have 2 microphones set up, so students and the general public, it's an intimate crowd, so feel free to come up if you have a question. I'll continue, but come right to the microphone so that we can get you on record if there was something you need clarification on, or perhaps you are planning to be a parent yourself, or you're a grandparent and your children are going to perhaps one day bless you with grandchildren. You may want to know something, if we can answer it right here. And of course, the full story is in ResearchER magazine, one of many stories being offered this month. Additional viewpoint from you. I mean, this is a phenomenal story I did not even know. And I think the thing I'm wondering is, how is the medical industry working with engineering? You know, are we going to see much more of this? We're not looking to create the bionic man, but this is...
Yes, we are.
We are?
Yeah, yeah.
Okay.
Yeah, and this is not going to stop. This is just the beginning of it. If you see the statistics out of all engineering disciplines and out of most disciplines out there and the workforce, bioengineering and biomedical engineering is the one that has one of the largest job growth indexes. And to go back to your question, when do I think this project is going to end? might never end, because this is a continuously evolving problem. As I said, we started from something very basic, very simple, understanding the mechanism, first identifying which ones of the muscles are the ones that play a role in the motion of the hip and the dysplasia and the reduction mechanism. Once we isolated these muscles, actually created the mechanism, then added complexity to the mechanism by having more realistic type of models, by having more anatomically specific or accurate type of geometry. Where do we want to go with these? If I can envision the future of this project, I would want to see, with the use of enormous computational power, the ability to have a baby, right? A baby with this condition, to have a CT scan of the hip of that baby, to be able to segment that into a 3D model, to do a patient-specific analysis on the hip mechanics of that particular baby, and to be able to 3D print a harness that is specific to that baby. Because every condition is completely different. We're not talking about just size, weight, shape. We're talking about many different parameters that make one problem completely different from the next. There's things like, for example, the anteversion angle, which, if I may, sort of if Dr. Price can point at what the exact definition of the anteversion angle, which is something I didn't know it existed, but he guides our anatomical perspective of these. So,
well, this would be the knee. So if you're sitting with your knee like this, then the ball actually comes up and points into the socket. It's not straight out this way.
Right.
And the angle at which it's turned is called anteversion. And so this one's actually, you made this one from a hip dysplasia.
50 degrees.
So the normal in an adult is 15 degrees. So this one is abnormal, and I assume
45 degrees or so.
This is a patient that had hip dysplasia.
That's right.
When you look at the socket, one of the things when they've just started working on this, they didn't have enough to do, and but in the adult, when you have to correct, you can do some correction in adults, but we don't know the combination, because one adult might be like this, another might be like this, and the total hip, for example, might fail or succeed because of the way this is replaced. And so now they're looking at the optimum angle to fix this. We can actually change it surgically, and then the relationship between this and the socket. So the anteversion angle there could be very important, and no one's really looked at that.
It changes the mechanics completely, and it turns out that the variance of these angles is enormous. I didn't know this, that two people can have such completely different anatomical parameters. It can go from 15 degrees to 45, 50 degrees.
Yeah.
So, and that completely changes the ball game. So it requires a completely different analysis. The results might be completely different, and it requires a completely different set of constraints to be able to reduce a condition.
Victor.
Yeah, just to mention that's one of the variables, that there's a lot more that could change. I was just talking to Jensen about it. I was saying, well, from the engineering point of view, rotating this on a model, it's fairly simple. Analyzing it, that's where the complexity is at. But now what we're looking at, it's rotating the socket of the pelvis. So that's what they call osteotomy. So that is going to be challenging, and we are looking into that as we speak.
In the research, arthritis can happen. It can increase the proclivity for a person. Does that mean, Dr. Price, that if undetected, a young person could have premature arthritis because they have this condition?
It definitely means that. If they have this condition, they will develop arthritis.
How young, possibly?
This is where the mechanics come in, because if the hip mechanics, if the ball is well contained in the socket, then the pressure is evenly distributed. But if the socket's off kilter like that, then when you walk, the pressure is not evenly distributed, and so the socket wears out too quickly. Or if it's anteverted too much, it can wear out quickly. And so a lot of these things they can apply stresses. You better explain how you do that.
Stresses.
Or something.
Yeah.
They can tell us what.
So what we're looking at, and Dr. Pratt said it, I mean, we're looking at a nice pressure distribution in the socket, and that's what we expect to see. So in most of the cases, whenever we do the baby wear analysis at different locations, we're trying to find out the optimum pressure distribution in the acetabulum socket.
So in a baby, you want to optimize the pressure so the socket will develop properly.
Right.
And in the adult, they're starting to make some 3D printed models of actual patient CT scans to help the surgeons plan how to reorient the socket so that it can distribute the pressure the best. Right now, we judge from x-rays. You go into surgery, you judge from x-ray, you make the cut, and you kind of go like, well, this looks like it fits here, and this looks like it fits here. I hate to say it, but it's kind of like that. So there's an art to it. And these people are trying to remove the art from it, which would be terrific. Then we could use computer-assisted surgical devices to put the hip in exactly the best place for the most people.
Wow. You know what, I'm listening to this, and I am not a scientist. I'm just the guy who got the honor of speaking with these folks. I'm thinking about chiropractic care. They say that when your hip is off, everything else in your body can be off. And so by doing this, if you can conquer this challenge, you may be able to save people back pain, leg pain, any number of additional issues. Am I correct?
Probably.
Wow.
Yeah. And a lot of athletes have this problem. Mary Lou Retton, who was a champion gymnast, actually had hip dysplasia as a child. She was treated and was successful for a while, but at about age 35, she ended up with both hips replaced. And so people can be good athletes. You can get through childhood after hip dysplasia treatment, but it pretty much is going to wear out unless it's a perfect result.
Yeah, I have a daughter who's a ballet dancer. Do I need to be concerned about her? She's 22 years old.
A lot of ballerinas have it, but if she's not having hip pain, she's probably okay.
Okay.
Yeah.
I was wondering about that. What about the device itself? Who makes them? Are they created here locally? Are they made somewhere else? The harness.
They're made commercially. There are a lot of brace making companies. There's no patent on the harness. It was developed by a Polish physician 80 years ago, and so anyone can make one. And so you can buy them commercially from a number of what we call soft goods companies. The same things, people that make ankle supports and wrist braces and things like that.
For people who are listening to this on radio later or watching on YouTube, is this something that would be, in other words, prescribed, diagnosed, then prescribed, so that you could get the harness and not to get too far afield into insurance, but they would cover this?
Oh yeah, but an improperly applied harness can damage the baby's hip. So the harness needs to be prescribed by a physician, and then the application needs to be overseen by the physician or the physician assistant, and then you came in once a week probably to have adjustments made to make sure it was doing the right things, because it can cause harm.
Once again, for the general public, how many hours a day should they wear the harness?
24 hours a day.
24 hours a day.
You can't take it off completely.
So you change the baby, you put the harness back on.
No bathing until she's out of the harness.
Wow, no bathing, just to make sure the audience picked this up, no bathing until the...
So she would, vomit all over herself. We could not take it off.
Wow, okay.
Sponge baths.
Sponge baths.
It's hard.
One strap at a time to change a onesie, and then one strap at a time to put one on.
You asked the question. It's surprisingly, it's really hard on the parents, and she's adapted very well. But as you can imagine, a lot of parents, it's pretty devastating. Like you said, you were expecting to take your baby home and have no problem, and then even though it's not life-threatening, it certainly is disruptive at a time when you're expecting something different, and it's hard work for the moms and stressful on all the people around them and everything else. And fortunately, if there's a great outcome, that's wonderful.
I want to put a call out for any questions anybody may have before we summarize tonight. If you would, to step right up to the microphone, speak into it, your name, your field of study. Thank you for being with us. Right into the microphone. You need to get really close. Thank you.
My name's Kian Kopp. I'm a senior in the Homeland Security Department. And my question is, for adults that weren't diagnosed as a child, like, how do they know if they have it? And what can you do? Is there like physical therapy?
For adults, thanks for the question. The usual sign is hip pain, and it's generally pain. Actually, your hip is here, so if you're hurting over here, it's probably a muscle, but the center of your socket is actually here, so it's more of a groin pain. and a hip pain, and it gets worse with activities, but it can also hurt when you're sitting or at other times. And so it's most frequent in young ladies, and pain is the number one thing. And the problem today is that I wouldn't say it's a new field, but we're discovering more things about it, and not all orthopedic surgeons are aware that this is a common cause of hip pain in women. And the average delay in diagnosis in young women is 5 years. So often they have hip pain for 5 years before it's detected, and they see over 3. It's usually the 4th physician they see who is experienced with it. So you can tell on an x-ray, but the first thing is hip pain. And for young people that have it, if it's mild, you can do some weight loss and lifestyle modification and activity restriction and things like that. But generally, it because of the mechanics of the socket, if it's there, it generally deteriorates until the body is realigned. It's like having a wheel out of alignment on your car, and the joint has cartilage on the top of it. That cartilage, you can think of that like the tread on your tire. And if the tire is well aligned, the tread's going to last longer. But if the joint's not well aligned, then the tread's going to wear out until you get it realigned. And these gentlemen are helping us figure out how to realign the tires so they work the best and preserve the cartilage. But so in adulthood, it's generally a surgical solution. But any young lady that's had persistent hip pain, now if you've been out playing volleyball and you twisted your hip and it hurts the next day, give it 6 weeks. But if it's consistent pain, then you should have it evaluated.
So it's not instant, is what you're saying?
No, and it gradually gets worse.
Over here, your question.
Yes. Hello, I'm Daniela. Aviation Business Administration, and I went to a doctor when I was like 8 years old, and then when I was 9, I got diagnosed with hip dysplasia, and I went to therapy and all that. Nothing worked really, and none of the doctors are offering me or saying to me that surgery is one of the options. And I'm in constant pain, and it doesn't change anything. And I went to therapy for like 3 years, and it didn't work at all. And I'm just letting you know that there are people like me that were in pain, and there are doctors that say it's surgery, but there is not option like for them. And I went from the United States and from Colombia, and none of them had like saying to me that there's a surgery solution for it.
Well, unfortunately, I don't treat adults, so but unfortunately, your story, like I said, is too frequent. That the average young lady with pain from hip dysplasia goes 5 years without a proper diagnosis and sees 3 or 4 doctors who aren't well trained. So my advice would be we can talk afterwards, and I can give you the names of 2 or 3 doctors that are really specialists in adult hip dysplasia, because the diagnosis is not as easy as you would think. But if you have that, there's definitely treatments for it.
I was just going to follow up. Does it move to orthopedic at that point?
Yes, orthopedics. But the surgical treatment in young adults, when you get to it early enough, they've looked at high-performance athletes, and about 50% of them can actually return to their high-performance athletics. And 90% are more athletic afterwards than they were before.
Wonderful.
Yeah.
Your follow-up.
My dad and my brother had PERDIS, and I don't know if that is part of why I have this.
It runs in families, it does. So there are genetic components that predispose people to it. There are endocrine components, the hormones that are around the time of birth, and then there are what we consider environmental components, like baby wearing or swaddling or other things. So, and it's much more common in some cultures.
We come back here. Did you have a follow-up?
Yeah.
Go ahead. If you get really close to the mic, go ahead.
You guys mentioned clicking of the hips. Like what is
Clicking is fascinating. A lot of babies will click, but it's a high-pitched click. And some people can snap their ankles, or when you squat down, your knees might click. So there are a lot of clicks that are normal. Most ladies that click, it's not hip dysplasia. If the clicking's over here, it's a muscle that's snapping in front and in back. There's a muscle that runs from up here down to your knee, and when you bend the hip up, that muscle comes in front. When you bend the hip back, it comes in back. So if you've got a clicking hip and it's on the side, then it's not hip dysplasia. The hip dysplasia is in here. If it snaps in here, then that's a different matter.
We actually have a demonstration of how her hip. This is great. First time ever one of our photographers can demonstrate. Go.
So it comes out and jumps.
See,
Feel it?
that's probably muscular.
No, like it comes out and then it comes back, and your pain is usually here.
Well, then, so you may have an unstable hip. That hurts to watch.
I was just going to say, I'm in pain. It's just standing here. Are you okay?
Even doctors are a little squeamish about that, you know.
Okay. One more chance for anyone who may have a question. Yeah, come right down and ask your question, and then I have a question for you about the heart, the other procedure, and then we will conclude our program. Your question, good evening.
My name is Arka. I'm a PhD student in Mechanical Engineering Department.
If you could write into the microphone.
My question is, what is the optimum amount of force we should be expecting a femoral head is exerting on the cavity?
The optimum amount of force, did you understand the question?
The optimum amount of force for what?
Yeah.
The femoral head should be exerting on inside the socket for a normal patient.
If I can address that, optimal in the sense of force, you've studied biomechanics, and you know how to calculate joint reaction forces, for example. This is one of the topics that we cover in our classes. And one of the things that's kind of surprising to the students the first time they take biomechanics is that, for example, some of the forces that are developing our joints, like the knee or the hip, can be 10 times our weight. 10 times our weight because of the different mechanical disadvantages that we have on the lever arms of the different muscles that play a role in a different articulation. So for example, standing in one leg can actually produce a joint reaction force on the standing hip that could be 5 to 10 times the weight of the person. And if that force is not evenly distributed, like Dr. Price pointed out, if the femoral head is not concentric with the acetabulum, with the socket, then you have an enormous concentration of stress at single locations, right? And what happens when you have enormous concentration of stress? You have what's called hyperplasia, right? Abnormal cell growth. You can have necrosis. You can have really, really bad flow circulation on the femoral head that can actually lead to the death of the femoral head, that can actually lead to then a hip replacement.
See, these guys don't need to go to medical school. I'll tell you what, they know more about hip dysplasia than most doctors do about this condition. It's really great fun to be with them. But if I could amplify that just a little bit, for people that have knee pain or hip pain, the doctor always says lose weight is the first thing to do, and trust me, I know how hard it is to lose weight. I used to weigh 100 pounds more than I do now, and so it's hard to lose weight. But for every pound you lose, because of the way the mechanics of the hip and the knee work, for every pound you lose, it relieves the joints by at least 5 pounds. So if your knees or your back is hurting, if you can lose 5 pounds, you don't have to lose everything, but if you can lose 5 pounds, it'll make a huge difference as far as the mechanical forces on your joints.
There's my motivation. Wow.
Just 5 pounds makes a big difference.
I could use a lot more. But let's talk about the heart briefly, a sidebar, if you will, about that, because I want our audience to understand how wide the research is here at Embry-Riddle.
Yes. So talking about the heart, as I said, we're fortunate to be able to work with very bright and talented cardiac surgeons. One of the conditions that we look at is what's called the hypoplastic left heart syndrome, which is a congenital heart disease. It's commonly known as a blue baby syndrome. It's normally it's a condition that occurs in 1 in 5,000 babies approximately, and it's completely mysterious. There's no congenital correlation. There's no developmental correlation. It just happens, and it has to do with the development of the left ventricle, which is the strongest portion of the heart. Is the pumping chamber of the heart that is in charge of sending blood to the entire cardiovascular system, what we call the systemic circulation. So when that ventricle is underdeveloped or it doesn't exist, basically the baby doesn't have enough blood circulation and enough oxygenation, and obviously the baby cannot survive. Fortunately, there's a connection, a natural connection in the cardiovascular system between your systemic circulation and your pulmonary circulation that keeps the baby alive for about 5 days. It's a natural connection that shuts down after about 5 days. So if doctors detect this condition, so usually detected before birth, they have to act before 5 days of birth with one corrective surgery, open heart surgery, completely stop the heart for a few hours actually. And then they have to do 2 more of those within a year to be able to not completely correct the condition, but help in the survival of the baby. So we don't work on the surgical procedure itself. We work on the outcome of the surgical procedure and sort of telling the doctor comes up with an idea of what if we put a shunt in this direction? What if we actually add a shunt? What size does it have to be? What direction does it have to have? Do we twist it? Do we implant it here? What angle in the coronal plane? What angle in the sagittal plane do we? So these are things that are relatively easy to do on the computer, in a computer model, or even in a benchtop or what we call in vitro model, but not easy to do in a person. So that actually makes a huge difference.
This is a great example of how research can better improve the quality of life for the next generation. This is a tremendous discussion, and I'm grateful to all of you. Just a moment, I want to tell folks about what we're going to be doing when we come back in a few weeks. We're going to change subjects. We're going to move back to cybersecurity. Another of our discussions with Dr. Kessler and Dr. Krager, and we're joined by Brad Deflin, the founder and president of Total Security. How much is the government watching you? Our speakers are going to talk about the latest challenges in cybersecurity, including identity theft, personal finances, and security. Monday night, March 19th, here on the campus of Embry-Riddle. Thank you, Tony Petro, for doing this. Jasmine, thank you so much for running the camera for us tonight. And thank you for the opportunity. This is all in ResearchER magazine, which comes out, I believe, twice yearly. And you can find it online. You can Google ResearchER magazine with an ER, and you can also go to our website, erau.edu. Thank you, Dr. Murmurani, for this opportunity tonight, and our guest, Dr. Divo, Dr. Huaymave, and Dr. Price. Ladies and gentlemen, thank you all. To our guests tonight. Thank you, and have a pleasant evening.